Welcome everybody. Thank you very much for joining our fourth Pan North East London CKD webinar. Last one of 2023. These will continue in 2024, I'm pleased to say. Thanks everyone for joining, taking time out of your busy lunch. We've got a great program today. I'm going to start by giving you a very quick update on the virtual CKD service. And I'm really delighted that Dr. Tom Oates, who's a consultant nephrologist and general physician at the Royal London Hospital, has come to join us today to talk about hypertension and chronic kidney disease. And there'll be some specific time for question and answer with Tom after his session. And then we don't have a specific topic, but I thought just at the end of the year, it might be good to end up with a general discussion of kidney disease. And I'll sort of put down a few house rules about how we're going to manage that. We can wrap up at 2 o'clock. We may get through it before then. Let's see. So I'm just going to quickly roll on with a bit of an update about the virtual CKD service. I need to tell you, first of all, that the forthcoming junior doctor industrial action, and of course there's a potential for consultant strikes as well, is going to be very disruptive to all our services, including but not limited to the virtual CKD service, which already has a bit of a case backlog. We're still trying to recover, as I think many other services are from the strikes last year. The backlog is worse for us in Newham and Waltham Forest. It is almost non-existent in Tower Hamlets and City and Hackney, fingers crossed, and we are working very, very hard to clear that as fast as we can. The forthcoming strikes, and of course over Christmas now with consultant leave as well, means that there is going to be a delay in us responding to your virtual CKD referrals, but they will all be answered. We log them, we keep them, we have them on our system. We will get back to you. I'm very, very sorry about the delay. It is very hard to understand exactly how long the strikes will go on for and exactly how impactful they will be. So I promise I will keep you posted about that. I wanted to go through a couple of other points about the service, and I can't see hands at the moment, but I will take your questions at the end. First of all is about referrals into the service, and then just to signpost you to some really, really valuable and excellent resources freely available online, designed by colleagues in North East London about how to manage CKD. And so my next couple of slides are about how to refer into the virtual CKD service. You should have got this slide deck. I'm happy to refresh it again. Just a quick reminder here that our service, the virtual CKD service, is really only for patients with chronic kidney disease who are currently unknown to any of our kidney services at Barts Health. It's for chronic kidney disease. It's not for acute kidney injury. It's not designed for urgent management of hyperkalemia or nephrotic syndrome, which are all renal urgencies and emergencies. And for these urgent problems, the renal on-call team at the Royal London is available 24/7. But if you've got a patient who is not known to any part of the renal service, who's got chronic kidney disease, and you need our advice or an opinion from us, then that's what we will offer you. Just a reminder, because this is a recurring theme, that when we offer your patients an appointment, they should never expect to come to hospital under any circumstances, nor would they expect direct and contemporaneous communication with a kidney doctor. We do a review of the EMIS record and leave a reply in the EMIS record for you to look at and digest and action. We don't call the patients, we don't video them, and we send them what we call a sort of ghost or dummy appointment on a Sunday morning. And over the years and up until recently, some patients have actually turned up at 8:30 on a Sunday morning, which is an awful, awful experience. So please remind you, and so please don't give them the appointment details. There's a chance they go out into the NHS app, which we're trying to control from our end, but it's particularly tricky. And another reminder that if your patient is actually already under the care of one of the nephrologists and they've got CKD, or they've got vasculitis or dialysis or transplant, please communicate directly with the normal consultant for that patient. I'll move on and talk about this, the ideal and or minimum data set. This is a recurring theme for us. I'm afraid that more often than not, we are receiving referrals where there is no clear question for us to answer in the referral letter, and that we do not have enough of the sort of the basic clinical and biochemical information that we would need to give you a useful response. And we did an audit of this recently. I think between 50 and 60% of our responses are requests for more information that is on this list, which is either something like what was a specific question here, and sometimes we're missing the most vital bit of information, which is the urine ACR, Usinese, hematology, and the blood pressure. So please do make every effort to get all this information available in your patient's record, ideally 6 to 8 weeks before referral. It may need to be more contemporaneous, but without this, and particularly without the question, we struggle. And what that means is that we generate a backlog of cases through interactions with you whereby we are not certain what question to reply to, or we don't have the information to respond to. So the best way to help us, to help you, to help your patients, and to make the service as efficient as possible is to get all of this data available for us in all your referrals. I'm going to skip over that because it's not relevant, but I am going to come to this CKD resources, and we've talked about some of this before. My wonderful colleague, Dr. Kieran McCafferty, and his group, Linda Tarn, have devised some guidelines on chronic kidney disease. I'm going to put the URL in the chat in a minute. This is on the London Kidney Network website, which if you haven't seen is well worth having a look. It's very easy to Google. Like I said, I'll put the URL in the chat. Kieran and Linda have worked incredibly hard on chronic kidney disease, how to identify, how to optimize in patients both with and without diabetes. There's a whole suite of guidelines that you can download. There's information here about interpreting proteinuria results, and also particularly really important here is a helpful patient information package. And just to give you a sense of this, if you've got a patient who has got CKD and type 2 diabetes, if you click on this link, then there's a golden set of information here about the 3 within 3, the 3 actions in 3 months to save lives, treatment with RAS blockade, SGLT2 inhibitors, statins, and blood pressure control, and a really simple step-by-step guide about how to use dapagliflozin resources for it. I refer to this all the time in my day-to-day practice. This is a particularly good bit here. Information for people living with chronic kidney disease, NHS guides, London Kidney Network information, something here about exercises, what to do with medicines when you're sick. It's really all there. And what I would encourage you to do is the majority of the answers in the early management steps are either in this package for patients with diabetes or for patients with CKD who do not have diabetes. And a reminder here that SGLT2 inhibitors are indicated for patients with proteinuria with a UACR greater than 22.6 who do not have diabetes. And these are game-changing medications, and Kieran and Linda have made it as easy as they possibly can to get the right patients, on the right treatment. So a great set of resources. We've talked also here about the kidney failure risk equation, which is there for you to use to calculate the risk of progression to dialysis or transplant requiring kidney failure. If you've got a 65-year-old male with an eGFR of 23 and a urine ACR of 200, you can punch in those details, click submit, and identify here the patient risk of progression to kidney failure requiring dialysis at transplant, both at 2 years and at 5 years. Very high in this completely made up example. And down here, again, some really helpful criteria for referral to kidney services from NICE. So I am going to stop sharing, stop talking, and I'm going to come back to you all here, and I'm going to drop this in the chat, and I can see there's been a few questions, and that's fantastic. And I will thank you all for listening. I think what we'll do in the interest of time is we will address these questions. Sophie and Shahid there will come back to those perhaps in our general chat. But I'm going to hand over to Dr. Tom Oates. Tom is a consultant nephrologist. He's a virtual CKD doctor. He is based at the Royal London Hospital, and Tom has very kindly agreed to come along and talk to us today about CKD and hypertension, a really important topic. And Tom, thanks very much for sharing with us today. Over to you.
Thanks. I shall just try and share. I have a few slides. Can you see them?
We can,
yeah,
yes.
I can see them and hear you.
Good. All right. Hi, my name's Tom. As Gavin says, I'm a nephrologist. I work at the London. So if you're from Tower Hamlets, you may have seen me responding to your virtual CKD referrals. So Gavin asked me to talk a bit about hypertension in CKD. I think the most important thing to start with is probably to say that I come in peace. You know, I'm well aware that essential hypertension, all the expertise and experiences in primary care, and that's true of hypertension in CKD that isn't treated with dialysis, transplant or immunosuppression as well. So I'm certainly not here to say, you know, this is how you should do it, etc. But I am here to maybe challenge what we actually all do, and I include that in myself, using some recent guidelines. So KDIGO, which is the Kidney Disease Improving Global Outcomes, which is the sort of main body that writes international guidance for nephrology, updated their hypertension guidance in 2021. And I'm just going to sort of show it to you today and show you how it certainly varies from what I do, and therefore I would have thought varies from what you do as well. Now, so has the slide moved on? Yeah.
It has.
Yeah, so this is their kind of pictorial summary of it, and you'll see at the top that the main thing that they've chosen to really kind of bang on about in this update of the guidance is how you actually check people's blood pressure. And that's this idea of this kind of standardized blood pressure measurement where you're not talking, you've got a well-fitted cuff, the arm is bare and resting, the mid-arm is at the midpoint of the sternum, the back is supported, the feet are flat on the floor, etc. And you've got a quiet room, no smoking, empty bladder, and you've relaxed for 5 minutes or over. Now, that's certainly not how I check blood pressure in my clinic room. I'll probably be honest, I probably check blood pressure in my clinic room more of a kind of laying on of hands thing rather than actually deriving a usable blood pressure, because I, like probably a lot of you, am encouraging and using home blood pressure measurements from patients. And you'll notice that is not what KDIGO chose to make the central point of their guidance, meaning not home blood pressure measurement, meaning they chose to make this standardized assessment. And for those of you who are sort of hypertensionologists, you'll know that that's kind of following the SPRINT trial, which I'll talk a bit more about as we go on. In 2021, they also, in this guidance update in 2021, they're also very keen to stress lifestyle modification. So salt intake less than 2 grams per day. There's more salt than that in a sort of pret-a-manger sandwich. So good luck. And then physical activity of 150 minutes per week of moderate intensity, which I'm sure you will share my way of saying moderate intensity is something that raises your work of breathing. In terms of what they actually suggest in terms of targets and preferred drugs, I left pediatric patients and kidney transplant recipients on there, but they're maybe not particularly relevant to this audience. But in terms of adults with CKD, both with and without diabetes, their target was for a systolic blood pressure of less than 120. Now, as you will know, that again follows the SPRINT trial. Just in case you don't know, SPRINT, I think, was published in about 2015, maybe, had 9,000 patients over 100 centres, randomised into intense blood pressure control, which was a systolic less than 120. And there were significant benefits for major adverse cardiovascular events. And so therefore intense blood pressure control has been seen as a way to improve intense cardiovascular events. There were no diabetics in SPRINT. There was no one with a proteinuria over 1 gram per day, and there was no one with stage 4 or stage 5 CKD, but it still formed the basis of the KDIGO hypertension guidance update in 2021. All patients in SPRINT had their blood pressure done in this standardized way. So clearly you all know this. The point is therefore then, if you're not measuring blood pressure in this standardized way, should you be treating people to a blood pressure of less than 120? And I'll be happy to answer any questions about that. In terms of preferred drugs, well, it should be ACE or ARB for pretty much anyone with CKD. I've just put what G1 to 4, or remind you what G1 to 4 means there. So G is this the GFR stage of CKD. And certainly anyone with severe albuminuria without diabetes should definitely be on an ACE or an ARB. And anyone with moderate albuminuria without diabetes should be on an ACE and ARB, but that's less decent evidence. And then in any diabetics basically with CKD should be on an ACE or an ARB. In terms of kind of the 7 main points from this guidance update, just in words, they're pretty much what was on that picture. This standardized office measurement is now what was stressed. Home measurement is seen as an addition and not the gold standard. The gold standard is seen as this standardized measurement. And if you have CKD and you're not on dialysis, then your standardized measured systolic should be under 120. This also applies to older adults. I agree with you if you're thinking, surely all my older adults will fall over if they've got systolics of 100. The problem we have with thinking like that is that SPRINT did not see an increase in syncope, postural hypotension, or injurious falls in the tight control group compared to the non-tight control group, and that was also seen, so there wasn't any increase in those adverse events in a pre-specified older adult group. And it also applies to those patients with increased albuminuria in this guidance, even though SPRINT excluded patients with a gram of proteinuria per day. They did therefore caveat this to say that the benefit of intensive blood pressure control is less clear for those with stage 5 CKD, whether they're on dialysis or not. It's less clear for those patients with severe albuminuria, which is an ACR over 30, and it's less clear for diabetics, which is clearly kind of against what we all do and think and have thought since the 1990s, which is that proteinuric diabetics should have tighter blood pressure control. Those with albuminuria should be treated with an ACE and an ARB, and we shouldn't forget lifestyle interventions. So as you can see, this is the problem with using guidance that's written by specialists and written by specialists within a specialty, because it's potentially not particularly reflective of what even I do, let alone what even primary care does. And so I think I don't want to do too many PowerPoints because I think it'd be interesting to talk about this. And this is just to remind you that it's certainly none of that looks anything like nice guidance about treating hypertension in adults. I'm not going to go through this because you will know it far better than I do. That's terms of targets, and it's sort of looks a bit like, but doesn't really go beyond the idea of ACE and ARBs. It looks a bit like this, which is nice guidance about pills and medications to use. But as I say, KDIGO aren't really going beyond trying to increase the use of ACE and ARBs in relevant patients. I would just make a point whilst we're on this slide that low-dose Spiro has become incredibly trendy in hypertension management. I'm sure you're all using loads of it, and I think we all need to get better at using more of it. And you'll see that step 4 in there. I include nephrologists in that. And I think the other thing I would say is that we shouldn't be as critical of using diuretics as many of us are. We nephrologists are kind of very poo-pooey about thiazides and thiazide-like diuretics, and I think alternatively a lot of non-nephrologists, be it in primary or secondary care, are very against using loop diuretics in hypertension management. And I think certainly in patients with significant CKD, and certainly those with signs of volume overload, you'll find it very difficult to get people's blood pressure normal without a loop diuretic. And there is recently, I was going to put it in fact I have, this is a recent nationwide cohort study from Sweden, which is sort of what we used to call retrospective cohort, which now is called real world evidence. I'm sure you've noticed that. And this was patients with CKD stage 3 to 5 who were already on an ACE or an ARB. And it looked at whether these patients were on diuretics or calcium channel blockers, and then pulled out some outcome data on them. And it did potentially seem to show that hypertensive treatment with diuretics may confer both benefits to the kidney and cardioprotection compared to calcium channel blockers, so kidney replacement therapy or major adverse kidney events. So I think we do need to think about how we use diuretics, because they've sort of become slightly unfashionable, and maybe that's not fair. So I was just going to kind of do a bit of a case, not because it's particularly wacky or instructive, but then it might sort of encourage us all to have a discussion about cases that we might all like to hear how we would have all done it differently. So this is a 68-year-old woman. She's been a hypertensive for a decade. She's been well controlled on one agent. She's been diabetic for 25-ish years, and she's on basal bolus insulin, and she has a GFR of 30 derived from a creatinine of 152. If I could see the chat box, I'd ask you all to write down what you think what her one agent is that's well controlling her, but I can't, so I'll just say that obviously it's everyone's first line antihypertensive, which is amlodipine 10 milligrams once daily. Now her UPCR is checked I'm not sure why it wasn't a UACR, but that's not really that important because she is torrentially proteinuric. So her urine protein creatinine ratio is, almost up at 3 grams per 24 hours. And her blood pressure is 147/89. So I think, although I'm, someone who taught me medicine said the first rule of medicine is don't fiddle. I think we do need to fiddle here. And I think certainly there is now decent evidence that if her hypertension is uncontrolled and she's got decent proteinuria and she's diabetic and she's got CKD, then she should certainly be on what is standard of care. So I would start her on, personally, I would start her on some irbesartan, 75 milligrams twice daily, and some dapagliflozin, 10 milligrams once daily. And that is both to get her on standard of care for diabetic kidney disease, but also the irbesartan in an attempt to improve her blood pressure control. Next time her bloods are checked, possibly up to about a month or so afterwards, her creatinine's gone up to 180, which equates to an EGFR of 24. Now, if she was being admitted to hospital for some reason, her irbesartan would immediately be struck off her drug chart, or I suppose clicked off it in the modern era. But I think it's important that, NICE and does mention, and I do use this idea of cutoff. So if GFRs fall by less than 25% or creatinines rise by less than 30% after starting an ACE or an ARB, and you genuinely believe that that patient should be on an ACE or an ARB, then you should keep going. And indeed, that creatinine rise is 18% and a GFR fall of 20%. So indeed, she did keep going on her irbesartan. Didn't really help the blood pressure though. So she's seen, and she is edematous. Now, she is felt to be edematous beyond what might be expected from her amlodipine. So she's put on 40 milligrams twice daily of frusemide to see if that helps both her symptoms and the blood pressure. And then over time, I'm not really going to quantify the time, but over time she does develop progressive CKD and her GFR slowly declines to under 20. So then the question becomes more about, well, what are we going to do now? So this idea about stopping nephrotoxins, I'm happy to have very lengthy philosophical debates about what nephrotoxins are if you really want, but I can't imagine a single person of you wants to have that. But sort of in reality, should we be stopping her irbesartan? Should we be stopping her dapagliflozin? Is the frusemide responsible for her GFR changes? All these things, which are what are frequently met, certainly by me and certainly by you in day-to-day practice. And I personally would say that there is nowadays, you don't have dapagliflozin 10 milligrams once daily. If it's started at a GFR over 25, you don't have to stop it. Even until the patient develops kidney failure. I think if she is significantly volume overloaded, then I would keep going with the frusemide. And equally now, the Stop ACE trial, which was published in the New England Journal of Medicine and was an entirely UK designed and run randomized controlled trial, showed that there was probably no difference in attaining kidney failure, whether you stayed on your ACE or ARB or whether you stopped it when you had stage 5 CKD or late stage 4 to stage 5 CKD. That randomized control trial does conflict with both retrospective studies and meta-analyses. So I guess you can choose what you like from the evidence pyramid in terms of that. So that was really all I prepared, but I'm happy to talk about things that have irritated you, annoyed you, or interested you in those slides. I'll stop sharing my screen.
Tom, thank you very much. Thank you for an evidence-based overview of blood pressure measurement and control. I'm sure there'll be lots of questions. Whilst our colleagues are thinking of some questions, I'm going to take you beyond the A, B, C, and D, which we're familiar with that process where we might have a patient who can manage 2 or 4 of those drugs, or 3 or even 4 of those drugs, and still has poorly controlled hypertension by whatever measure. And then you're getting into drugs beyond that, which we're familiar with doxazosines, the moxonidines, the minoxidils, etc. When you get to a patient who's got sort of maxed out on their ABCD and they're still got poorly controlled hypertension, where do you go next in the context of CKD?
So I think in the context of CKD, if they've got a decent, good going CKD, so a GFR less than 30, then I kind of hinted at it may well be that we're not doing the diuretics well enough with these kind of patients. Patients certainly with a GFR less than 20, I think you'll find it very hard to get their blood pressure normal on 3 agents, and you'll find it very hard to get their blood pressure normal without some kind of diuretic. Away from diuretics, I'm a big fan of doxazosine. I'm sure some of us are old enough to remember the All Hat trial and how doxazosine seemed to not be a great drug, but I think it works very well. It has knock-on benefits on men with bladder outflow obstruction because it's basically tamsulosin as well. But a lot of patients do get side effects from doxazosine. I must say the only people I prescribe moxonidine to are ones who are under my nose, so dialysis patients. I think it's I think it's not a widely used drug. I think it's difficult to expect people who don't use it to be keen on it. I don't prescribe minoxidil at all anymore after I've seen 2 patients with pericardial drainage requiring pericardial effusions after it. So that's it really. I mean, yeah, I think fluid status is so important in hypertension management in patients with advanced CKD.
Thanks. Okay, there's a hand up here from Hiran De Silva, and then a couple of questions in chat. Hiran, what would you like to ask?
Hi, can you hear me?
We can.
Hi, thank you for this. I'm a GP. I just wanted to know, before the patients that's been newly picked up with CKD, I've got a patient whose eGFR was 30, quite high blood pressure, and is awaiting review by yourselves. Is it safe to start an ACE inhibitor? Because you mentioned about thresholds of a fall. I just worried I don't know what's going on with this patient because she's not diabetic. She's got a family history of renal failure. Her brother had a transplant. She's got a lot of protein just under the nephrotic range. And I'm just worried about, I don't want to cause any more harm, basically. So what would you say in that situation? Is it okay to start ACE inhibitors, diuretics?
I guess my question would be, what harm do you think you're going to do? Do you think you're going to push the
I don't want to knock it off any further because I don't really understand what the process
I mean, so then I guess the idea is just do another blood test and see if it's getting worse. I mean, if it's the same as it was when you did the first blood test, then I think if they're significantly hypertensive and they've got significant proteinuria, they're going to end up on an ACE or an ARB, whether they've got the rarest kidney disease in the world or whether they've got diabetes. So you might as well start it either way. I think what I would say as a nephrologist is, I see a lot of people in virtual CKD, and this is in no way a criticism. I see a lot of people trying to do medicine on one U&E result, and that's really like trying to do it with your one hand tied behind your back. So I think nephrology is all about changes in results rather than results themselves. So I think if you have concerns about that, then just do some more results and see where you are before you make any change.
Can you just remind me what were the thresholds you said? Was a 20% fall in eGFR?
It's let me get them right in my head before I say. So it's a 30% increase in creatinine and a 25% fall in GFR.
So it's one of those, basically. All right, thank you.
And the reason NICE gives you both is because pedantic idiots like me will say that, if you're talking about acute changes in kidney function, you should talk about creatinine rather than GFR.
When with your case study, you use irbesartan rather than an ACE. Was that just your preference, or what was the rationale there?
That's pure preference based on my long-term what I've been doing since I was an SHO. Basically, I can't give you any evidence base for that.
Okay. All right, thank you.
Thanks. There's another question here, Tom, in the chat about irbesartan from Dr. Schiller. Looks like the rationale behind prescribing 75 milligrams BD, I think for the patient you discussed, as opposed to 150 milligrams once a day.
Yeah, again, I've always prescribed it as a BD drug, and it's just what I do. There's no evidence base for that at all. I think it allows you to It allows you to have a few more increments, so you can start with 75 once a day, then 75 twice a day, then 150 twice a day is how I would increment it. So yeah, that's just me being a stuck in my ways old man.
I would personally give 100 milligrams once, 150 milligrams once a day, but that's just me because I'm also stuck in my ways. So there's just some intrigue to the de facto mild antihypertensives. Since you frequently have to reduce antihypertensives shortly after initiation, Tom, how would you approach that?
So I think the answer to the first bit is probably yes, but the answer to the second bit is I'm interested because I haven't seen that, I must say. But as I say, I think Dr. Dada boy, you're probably doing this. You're probably seeing many more patients than I am where that's relevant. Because there is this idea that they're basically just diuretics, right? SGLT2 inhibitors.
About this topic, otherwise we're going to throw the floor open more widely to a general chat about CKD. Tom, could we sort of in the fullness of time get your slides perhaps to send around as a package? I downloaded the sprint study. I thought we could send that around to our colleagues as well for some light reading. Hiran, you want to come back with a point there?
Yeah, sorry, I just got another question off the top of my head. Could you touch on prescribing vitamin D in CKD? Because we got vitamin D deficiency or insufficiency is sort of endemic, really. And
yeah,
what's appropriate prescribing in renal impairment?
Sure, we can. And there's just a blood pressure related question here, if you don't mind. I have a particular interest in vitamin D, which I will happily address that. And we just come at Gift, you got a question about ramipril. BNS says maximum daily dose 5 milligrams if creatinine clearance 30 to 60 mils a minute. Initial dose 1.25 if creatinine clearance less than 30 mils per minute. Should we be reviewing all our patients with creatinine clearance? Tom, thoughts on that?
That's the dangers of reading the BNF, isn't it?
Exactly.
I mean, I've never seen that before. I've never done that in my life. So yeah, I've got patients on dialysis who are on 10 milligrams of ramipril.
Yeah.
I mean, I'm sure. So it's this. I mean, I don't want to just make this my opinions, but the BNF and NICE and everyone is so obsessed with hyperkalemia, and not real hyperkalemia either. So hyperkalemia of 5.5 or something. But I think that's where a lot of these come from. So that is. I'm in no way advocating ignoring the BNF, but that is in no way anything that I've ever built into my practice.
Yeah, I agree. I can't fathom that rationale. I will always try to get someone with proteinuria CKD and a maximum dose of ACE inhibitor. The overwhelming majority of trials in the field of CKD and now the SGLT2 inhibitors are based on the premise that patients have sort of got a maximum tolerated dose of an ACE inhibitor. I think the risk of giving someone 1.25 milligrams of ramipril is it not only does it not do very much, but there are another 4 increments, often with this philosophy of, well, you should repeat the use and use 10 to 14 days after each increment. It takes ages to sort of get up to a really decent dose of ramipril. So I don't recognize that bit of advice from the BNF. Right, colleagues. So we've got 25 minutes for a chat. I'm aware there's a medical emergency on my dialysis unit. I'm just hanging on the phone. There's a colleague there who's sorting out, so I may have to disappear at short notice. I apologize about that. We're going to have an open chat about CKD, and I'm just thinking about all the things that we've discussed as a group in the last 4 webinars. Before we do, please do not mention patients' names, NHS numbers, hospital numbers. We should really keep this confidential. I'd like you, please, not to screen share your patients. I think that's in breach of the information governance guidelines. But if you want to discuss some cases with concepts, we'd be happy to do that here. And you had a point about vitamin D, whilst our colleagues are thinking about some other questions, myself and Tom. Here, do you want to just say it again? You talked about was the question, should we prescribe or how should we prescribe?
No, so the different preparations, because some of them are metabolized by the kidney, aren't they? And then some are more suitable, are already biologically active without the kidney.
My thesis was on vitamin D, endothelial function and chronic kidney disease. Bottom line, vitamin D is good for the endothelium in stage 3 to 4 chronic kidney disease in patients who don't have diabetes. And in that study, we used ergocalciferol, vitamin D2. However, there's a worldwide shortage but that's because there was a worldwide shortage then of cholecalciferol, but the wheels have turned now, and the most predominant non-synthetic form of vitamin D at the moment is vitamin D3 cholecalciferol. If you think a patient really needs to be on a synthetic form of vitamin D like alpha calciferol, they probably need to be under a nephrologist or heading towards that stage of CKD. So I tend to give cholecalciferol because I know it's reliably available. I tend to give international units per week. Some of my patients forget to take it on a weekly basis. They prefer to have a daily dose of 1,000 units of cholecalciferol. I could go on and on about this. I won't. Target levels of vitamin D, in my opinion, are wrong. We're supposed to aim for greater than 75 nanomoles per litre. What does that mean? 200, 300 or 76? It's still unclear to me. The reason I use vitamin D3 is to try to get control of parathyroid hormone in the context of secondary hyperparathyroidism in chronic kidney disease guidelines. There is an absolute, and I don't want to say the word pandemic because it's very triggering, but there's a lot of people, the overwhelming majority of people in East London at this time of year who have got undetectable levels of vitamin D. It costs more to the 25D level than it does to replace vitamin D for a year. So there's a few factors in there, but to summarize, I use cholecalciferol 1,000 units a day. I hope that helps.
Okay, thank you.
All right, no problem at all. So colleagues, open mic, open floor, open questions, comments, criticisms, thoughts on the webinars, thoughts on CKD care in North East London. You've got two nephrologists on the line, happy to answer your questions about CKD. Fire away, what can I say? Tom, do you want to add anything? You sit there working in East London, you do virtual CKD, you see the whole spectrum of kidney disease. What else is on your mind whilst our colleagues are thinking of some challenging questions for us?
I think if you're sending someone's U's, you should send their albuminuria as well. Is the kind of what the way we should all be thinking about this now. That it's kind of we're not, the evidence base around using SGLT2 inhibitors in CKD is so strong now that we should be getting as many people as we can on, and the way that is helped is by knowing whether they have albuminuria or not.
Yeah, it's never been more important to measure proteinuria, to measure the albuminuria. It's a golden era of CKD drugs, which a lot of them, not all of them, are predicated on that premise. I entirely agree. There's 59 people on the call. I can't believe there isn't a single question about CKD, unless, Tom, perhaps our webinars have been so successful and our teaching sessions and interactions with the GPs have been so comprehensive. Alas, not. Shahid, tell us what's on your mind. How can we help?
Sorry, this is a bit of an obsession at the moment. I'm trying to reclassify all my CKD patients according to the new criteria, the new biphasic ones. First of all, is there an easier way to do it rather than just go through them individually and then tot them up on? Is there a tool that would help with that rather than just looking at the grid for every single patient? And secondly, I'm being really naive here. Does it alter? How does it alter management on the new nomenclature?
Show everybody what's at stake here. I'm going to just share my screen again. I have got, again, from the London Kidney Network page that I showed you. This is the document about coding in CKD. I hope you can all see this, and the rationale for coding and how to code is all in here. And there was a lot of debate about this, and it's quite a lengthy document, and it lays out the pros and cons of changing from where we were sort of a stage based to a sort of a G stage and an A stage. And in this document, and furthermore, if anybody's looking to see how to code with the new nomenclature, it's all here. It's not radically different, but the EMIS and the SNOMED codes are different, aren't they, Shahid? And there is an exercise about reclassifying patients with an existing CKD code into the G and the A stages, which is advocated by this document. I am entirely sanguine about the fact that that is a process that takes time. I would further say that probably more important than reclassifying those patients is finding those patients who do not have any form of code for CKD and giving them both a G code and an A code. There's a huge amount of evidence for the benefit of coding that came particularly from the National CKD audit that our colleague Sally Hull ran. And what they found was that if you have CKD and you are uncoded, you are 40% more likely to experience any form of urgent hospital care, even unrelated to your CKD. Furthermore, our colleague at the Royal London Hospital, Adio Leighton, identified that if you have CKD but do not have a read code for it, you are 8 times more likely to crash land onto dialysis. So there is massive by sector between sort of 15 to 25%. And in City and Hackney, I have a great time sitting down with GPs in their surgeries or online, and we do registry reviews of patients who have got biochemical evidence of CKD but are not coded. And that has really pushed our coding levels right up to about 100% in some sectors. And from coding comes a dialogue with patients. You've got CKD, this is what it means. Let's review your treatment. Let's modulate the risk. Let's look at ACE inhibitors, angiotensin receptor blockades, etc., SGLT2 inhibitors. So coding there's a huge amount of value in that. And Shahid, the rationale for that change, it's quite a big change, is in that document. And again, that will come. I should put that in.
I mean, sorry, just to feedback, I actually am using the kidney risk equation, which is absolutely brilliant. Yep. So you plug in basically 4 parameters, and it gives you a lovely printout, which I send in PDF PDF format to the patient, which provokes a discussion, and at least they know.
Yeah.
I think the problem at the moment is many patients don't even, they've been coded as CKD even, but they actually don't know that they're actually on this CKD register. The only little shame about it is that I just wish that it probably can't do it, but I wish the kidney risk equation calculator would actually give you the new criteria, the new classification, as opposed to the old one. But I think I'll just have to painstakingly go through the ones that I have done.
I think there's a couple of things to say. That the historical NICE guidelines encourage you to refer based on the stage of CKD and based on the GFR. And that has now changed into a risk-based approach to referral. And so the KFRE and the NICE guidelines say very clearly that if the KFRE is at 5 years is greater than 5%, that should prompt a referral to a specialist. And that could easily be the virtual CKD service. But please don't everybody refer every single patient with a KFRE greater than 5%. The most valuable part about our interactions between primary and secondary care is the lens through which you view a patient. So an 85-year-old in a nursing home with a KFRE of 6% is less likely to benefit from Tom's input than, say, a 45-year-old South Asian hypertensive percent. So I think that's really important. There is no tool, Shahid, that automatically codes CKD in EMIS, which I think is the crux of your question, that you cannot just click a button and have everybody coded appropriately. And there is a big piece of work about, once you have coded a patient, is how do you explain that to a patient? How many patients with a CKD code in your surgery actually know that they have got CKD and what it means? And I've explored this recently with a group of us at national level about what is the gold standard way of telling someone they have CKD. When you do these reviews and you code the patients, as you rightly should, do some patients need a letter with a call us if you want to make an appointment to discuss this? Maybe. I don't know. And I could not find a gold standard, but there has to be some communication to your patients that they have CKD. And Kieran and Linda, who wrote the guideline, one of the big things you'll see when you read them in detail is tell the patient they have CKD. And coding can prompt that dialogue. That's quite passive aggressive for me to sit here in secondary care and say, well, you should tell all your patients code and you tell them they've got CKD. It's a big volume of work, but it's potentially really important work as well.
Yeah, the reason why I'm enthusiastic about it, because I dare I say this, we're talking about nephrology and kidneys at the moment, but there is actually a convergence between all the other cardiovascular stuff and this at the same time. So this, for me, the reason I'm interested is because this is actually a very big hit. It covers several bases in one go, rather like SGLT2s do actually. But the key thing is that it's just, I feel that you could do a lot of good in one hit with, and it maybe it's worth the investment of doing that. So it'll have carry-on effects in terms of people's vascular health as well. Because the end points are the same. It's the same stuff. Pressure, increase, sort out your lipids. It's a big hit in one go. So for me, it's worth the investment.
Yeah, I agree. And what we're coming up with, I think not just in North East London, but really much more globally, is a cardio-kidney metabolic approach, or a cardio-kidney metabolic thought process, recognizing that something like CKD, albuminuria particularly, is going to be a trigger for an evaluation of that sort of triumvirate of very significant medical issues. So thanks for the very good points. Colleagues, we've got 10 minutes left. We remain open-minded and open-hearted to communicate with you. Some questions, some challenges. If you want to tell us what to cover next year in these webinars, we'd be delighted to hear about it. Joe, just whilst you're there, Joan, if you could maybe get the feedback questionnaire ready for our colleagues, because in that questionnaire, you could certainly put some of the topics you'd like to hear about. Anything else on anybody's mind, or are you looking for time? Here we go. How to communicate directly with the patient's nephrologist. You did say that right. Now, I don't want to speak for all. I don't know how many nephrologists there are in East London. There's about 25, 30 of us, and I don't want to speak for all of them. Certainly me, if I've got a patient who is under my care and you want to email me directly, that's fine. You can find me on the NH. There are generic email addresses, and I have got one up. There should also be on the letters that we send out, you should also be able to find, here we go, you should also be able to find an email address. And I'm sorry if that's not the case. I am going to put that in there. There is and please don't use my name when you email that, because they'll get really cross. But you shouldn't be shy about contacting us. I can't think of a single one of our colleagues who would be, reticent or upset to hear directly from you. If you've got a patient under care, just please be in touch.
People seem to write to me with Accurix as well nowadays.
Yeah, get that by email. All right, everybody. Listen, I think that was a great session. Thank you, Tom. Thank you, Joanna. Particularly Thank you, Joanna, who has organised everything that has happened this year in terms of these webinars has come from Joanna. Brilliant. All the emails you've got, all the bookings you've got, done an absolutely incredible job. Thank you so much, Joanna. I'm hoping just before you go, there you go, there's a feedback. Colleagues, there's 52 of you on the call. If half of you more give us some feedback, we can make this even better next year. What topics do you want to hear? What works well? What doesn't work well? Do you want us to come and do some CKD registry reviews? Do you want us to reshape our focus? How can we make kidney care better in East London? We're doing really well. There's a long way to go. There's a big coding gap. There's a big gap between the number of people eligible for SGLT2 inhibitors who actually should be on them. But we are making fantastic progress, and I hope these webinars have been a vehicle for that to become a reality. Thank you also to Tom. Thank you for you to join us. Good afternoon. Happy Christmas. Happy New Year. Happy holidays. See you in 2024.
Thank you so much, Gavin and Tom. Thank you.